I'd now like to introduce Dr. Julia Ishare, who from the Dalio Center, the director of the Dalio Center, who's going to say a few words of welcome. Welcome, Dr. Ishare.
Thank you so much. And I will be brief because I've seen a number of questions in the Q&A, so I want to give ample time for our phenomenal panelists to be able to answer them. And I would like to just say thank you, and thank you to the wealth and breadth of conversation and discussion that we can have now because of the information provided today. And so I'd like to say thank you to Dr. Poe, Dr. Tumalapalli, and Dr. Hussain for really expanding the conversation around disparities, but not just identifying the problems, but helping to advance the solutions. So I think in every case, we understood how could we think about solutions in algorithmic bias? How can we think about policy solutions and advocacy? And how can we also think about increasing education to increase the patients that we have, the Black patients that we have on our transplant lists? So thank you to all of our speakers today. I know there will be a healthy conversation in our following Q&A. And before I pass it back over to Dr. Silberzweig, I would also just like to say thank you to Dr. Silberzweig, who's moderated both of our symposia so skillfully and has really helped us to advance the conversation across our enterprise. So thank you, Dr. Silberzweig. Thank you to the Rogosin Institute for partnering with the Dalio Center for Health Justice to bring these quite important topics to the forefront. Dr. Silberzweig.
Thank you, Dr. Ishare. We do appreciate your partnership in this effort and your leadership of the discussion that needs to be had regarding disparities in healthcare. Rachel, you're here. Do you have a question for us? It looks like Dr. Poe doesn't appear to be on yet, so why don't we start with questions for our other presenters.
Okay, good afternoon, everyone. Thank you for joining us. We could start with questions for Dr. Leica. The question says there has now been more than 25 years of adding estimates of GFR to serum creatinine and following patients with CKD. Is there good clinical data to support the notion that using estimated GFR adds significantly to using the serum creatinine and closely following the patients? This is asked because of the very large uncertainty in the relationship between measured GFR and estimated GFR, and the large disparity between estimated GFR and the symptoms and clinical course of patients.
Yeah, thank you for that excellent question. So I do think that there is evidence that using the estimated glomerular filtration rate as opposed to just the serum creatinine is important, especially for patients with on the extremes of body mass, or really all patients, because as we know, there are non-GFR determinants to creatinine. And so creatinine would be higher in patients with higher muscle mass, depending on their diet, et cetera. So it is important to use EGFR, but it's not the only thing that we should rely on. Again, as Dr. Poe, so importantly discussed, it is a non-precise estimate. And so the P30, in terms of the variability of what the EGFR tells you, is actually the measured GFR. It only gets us within 30% of that actual GFR a certain percentage of time. So we should rely on other measures of kidney function. So ordering cystatin C when it's appropriate, doing a 24-hour urine collection, and using all kind of information that we have about the patient at our disposal to try to estimate their kidney function, especially if an important clinical decision is being made. So for listing for transplant, if you're thinking that they're at the threshold of EGFR of 20 and you want a better estimate, using all of these things at our disposal.
Dr. Poe, if I might follow up on that, it looked like when you showed the data for the P30 around the refit equation, it looked like there was more error for Black patients at lower levels of GFR. How concerned should we be that that might impact on referrals, as we've been talking about?
Yeah, well, I think that's kind of the price that we have to pay for, given this relationship between creatinine and African-American race, that if we want to eliminate race, there's going to be trade-offs. And as I tried to show in fact, both in bias and accuracy, but I think what Aleka was saying about our precision in these estimates is not perfect. And so the important thing is to bring in other data to get at what a person's true GFR. And I would also say not only EGFR, but also albuminuria, which is woefully inadequate in terms of testing among patients who are at high risk of progression, even patients with diabetes.
And that's actually another great question for you, Dr. Tamalapalli, is you listed several actions that we might take at the federal level. One thought that people have raised is looking at the Medicare wellness evaluation and whether that might include some of the specifics, as Dr. Poe just suggested, including albuminuria and a serum creatinine.
Yeah, I think that's a great point, Dr. Silberzweig. So just to review the data, among patients with diabetes, about half of them get albuminuria screening. And among patients with hypertension, even though the prevalence of albuminuria is quite high in patients with hypertension, about 10% only get albuminuria screening. And so we have a long way to go in terms of improvement. And I think the new kidney health evaluation measure that's being put forth by the NKF is a good start. So that's now a HEDIS measure and is being hopefully incorporated in the MIPS program. So including that measure as well as the wellness benefit, as you talked about, I think are excellent solutions.
Great, thank you. And Dr. Hussain, how much of the disparities that you showed in terms of preemptive transplant, for example, do you think is related to late referral to nephrologists? And do you think that some of the earlier screening tools that we were just talking about might improve those disparities?
I think that part of it is certainly due to late referral, but if we look at the kind of median GFR among patients who are preemptively listed, who are African American or other race, we see that they're the same. So it suggests that at least people are taking GFR into account somewhat when they among patients who are actually under the care of a nephrologist. I guess the big question is there a way for us to ever capture when these patients exactly are getting referred along their course of kidney disease, and are they getting sent to nephrologists in time to be preemptively referred if appropriate? Unfortunately, I think there's not great data to capture that, and any other speakers who feel differently can, of course, correct me. But I think in the absence of a kind of a more robust CKD registry that has a really diverse data set in terms of socioeconomic status and race and insurance status, it's very hard to answer that question. So I think we know that for sure that referral rates to specialists are worse among patients who have socioeconomic deprivation or are racial minorities. So I think it's very plausible that is one mechanism of that disparity, but it's certainly hard to prove.
I wonder if that's not a research question we might all collaborate around trying to analyze when those referrals are made. Rachel, did we have another question?
Yes, we have this question for Dr. Poe. Do you consider the foods that are available to those in Black communities compared to those foods in the white communities? Do you think that may be a factor in all the disparity?
It is possible. I've done some work to look at, even to try to explain dietary habits and progression to kidney disease. Mm-hmm. And a lot of work has been around the effect of healthy diets, such as the DASH diet, with high fruit and vegetable content and dietary acid load. And in fact, we know that there's more food insecurity or food deserts in many neighborhoods. All of these, a lot of the factors that I think Dr. Tamalapalli showed track together in these underserved and under-resourced communities. So that certainly could be part of the contribution to disparities. I wouldn't say necessarily all of it, because I think this is multifactorial.
Absolutely.
Thanks, Dr. Poe. And Dr. Tamalpally, you showed data regarding control of risk factors for chronic kidney disease like diabetes and hypertension. How much of a factor do you think diet and availability of certain types of foods plays in that?
Yeah, there's some interesting research on food insecurity and diabetes done by Hilary Seligman at UCSF and San Francisco General. But interestingly, the food insecurity, kind of the lack of availability of constant food, can impact glycemic fluctuations. And so, at sometimes their diabetes might be worse controlled or better controlled, and could lead to DKA. So I think it definitely is a factor. But I think the healthcare delivery system factors are also very important. So diabetes is a long-term chronic condition, and our healthcare system is so fragmented. So often patients transition primary care physicians. If they change jobs, they might change health insurance and then have a provider that used to be in network is now out of network, and they have to change doctors. So all of those factors, when you're dealing with diabetes over such a long time frame, diabetic nephropathy takes 15, 20 years to develop. It really takes this sustained effort. So I think the healthcare delivery aspect is really important. Our healthcare delivery system is so complex, and so it's so challenging to really make headway there.
Great, thank you.
Okay, we have another question for Dr. Powell. With the new estimated GFR equation, do you think that we sacrificed accuracy with that?
No, I actually think that these are all not perfect. The accuracy is not perfect in many of the estimating equations. I think what we fixed was the potential bias, okay? And I think the accuracy, is not, with one exception, and that is when you use two markers, like cystatin C and creatinine, those equations actually have superior accuracy than the other equations. But I don't think we sacrificed, I think that was the needle to thread here, not to sacrifice accuracy and not to create bias.
Okay.
And I think an important part of that, as you've been saying, is that the estimated GFR is just one of several measures that are important in assessing a patient's kidney function. And so it shouldn't entirely be based on the EGFR in terms of nephrology referral, transplant referral, et cetera.
Absolutely. And in fact, one of the things that I could have mentioned is that, we have these threshold values, right? A value of 30, GFR 30 to refer, a value of 20 for waitlisting, right? That's healthcare equality, okay? Because everybody has the equal threshold. But healthcare equity is giving people what they need. And if we know that individuals progress faster, then why shouldn't we give them what they need? And maybe a different threshold value is a better way of achieving health equity and the healthcare equality threshold values that we have been living with, for the last couple decades.
That's actually a very interesting thought. Dr. Hussain, what are your thoughts on access to transplant and perhaps earlier listing for patients, even if it's not, as Dr. Poe says, based on a GFR of 20?
I think it's a good start and a good thought, but I think anytime that you add more complexity to the decision to refer and the qualification to refer, you add a potential area for a disparity to exist. So, who is going to have access to doctors who are smart enough to figure out how they can make the numbers look such that they are higher, kind of at risk of a higher degree of progression? I think the way I like to think about even the old way we used to use EGFR for things like transplant referral or anything else is that really it's up to the provider to use the estimate or whatever other tools at their disposal to provide the patient with the best possible access to care. So there's nothing in the guidelines that say who can be listed for transplant, say you have to use the kind of designated African-American estimate in order to refer someone who is kind of a self-identified Black race patient. You know, you have just the same permission to say, okay, this patient has an EGFR of 19 using the white estimate or non-Black estimate, and 23 using the Black estimate. I think that white estimate or non-African-American estimate is more pertinent to them. I'm going to refer them. It's really the providers who are perpetuating that by kind of taking the easy route out and saying, well, I'm just going to rely on this. I'm not giving it any thought. You know, you have to have some gamesmanship if you're going to take care of your patient the best way. And the number one way to do that is to understand the system. And I think, unfortunately, in that potential thing that Dr. Pope suggests, the people who are going to understand the system the best are doctors who are taking care of wealthy patients.
Yeah, I think if I could just add on to that, I think that was the rationale for many institutions that said, let's just remove the race modifiers and give the range of values. And that was done in a number of institutions. Even the first institution at the Beth Israel Deaconess Medical Center in Boston in 2017, they took the approach of removing race by removing just the race reporting, but reporting a range of values of the non-Black and the Black estimate, and allowing physicians to use their clinical decision-making to make judgments about what the patient needed. There are a number of other institutions that did it that way initially as well.
And I wonder too whether we might envision sort of a revamping of listing of patients and take into account some of these other factors. For example, we know there's a close relationship between the degree of albuminuria and progression of chronic kidney disease, so that perhaps one might anticipate the ability to list a patient who has a relatively higher GFR with a higher degree of albuminuria. What do you think about that, Dr. Hussain?
I think that, again, it's a very good thought. Ultimately, it doesn't address the biggest issue is that it's not that these patients are getting referred slightly later because their risk assessment is inadequate, or that their GFR estimation is overestimated GFR, but rather they're not even making it onto the wait list even months or years after they start dialysis. So I think Dr. Poe alluded to this, and I don't want to put words in his mouth, but I think that focusing on kind of setting the thresholds for who can be preemptively referred is going to just be the tip of the iceberg, and really will not actually address the issue of patients even on dialysis who are clearly eligible for transplant have very, very disparate access to referral, to evaluation, to getting on the list and getting a transplant once they're listed. So that's a very, very small piece, and I think it will make us feel good that we're fixing quote unquote the system, but doesn't actually address larger underlying biases that impact access to care.
And if I could add to that, that's really where designing good systems comes in. And so, Dr. Hussain has done a lot of work in behavioral economics, and you can't rely on kind of individual clinicians to kind of have this high cognitive load decision and be making the right decision every single time. We need to design smart systems. So, for example, a default order in the electronic health record, or some proactive way of reaching the patients when they get to a certain threshold to ensure that they are listed. In the QI literature, that's sometimes referred to as a forcing function. So designing systems that ensure that these things happen regardless of the individuals that are at play.
And I think that what you're all suggesting is that there's a certain amount that we in the medical field can control, but that perhaps we need larger partnerships. For example, some of the disparities that you were talking about, Dr. Tamalapalli, regarding access to medications, right? Could we enlist pharmaceutical companies, for example, in dealing with drug prices? Obviously, it's something Congress has talked considerably about as well. And in terms of expanding insurance coverage, might we include some of the health insurers in those discussions?
Yeah, absolutely. Aligning incentives across all of these players rather than each player acting in a silo to maximize their own incentive, but really kind of having the patient be the central guiding goal of all these efforts.
Great. Rachel, we have time for a couple more questions.
Okay. This I'm just going to throw out to the group. Was there any thought given to how using the new estimated GFR equation will affect comparisons to the previously calculated estimated GFR in individual patients? And how should one go about discussing this?
Well, I can start with that. So it does affect the prevalence, and it will increase the prevalence slightly in individuals, African-American individuals. But it will also affect the prevalence in non-African-American individuals as well. One of the things that the task force, importantly, I didn't have time to go over this, we had 9 really central questions for future research and quality improvement efforts. And one of those was to look at the consequences and the impact of the new equation. So we weren't naive that we didn't think that this would have consequences, and we and I know there are many around the country who even begun to look at the impact nationally as well as within their specific populations. And we need to do that. I mean, this evolution of estimating this physiologic process is an evolution, and so we need to get better at it. We need to monitor the impacts of the decisions that we make, and we need to readjust and have better ways of estimating GFR.
Thank you, Dr. Powell.
Well, it looks like we're out of time. I'd like to thank today's speakers for their participation and for their wonderful presentations. Most importantly, I'd like to thank them for advancing our conversation on health equities, on noting the disparities that exist and helping us think about ways to address the disparities so that we can achieve true health equity. Again, all of us can participate in that conversation and should, and help us to really move forward in this effort. I'd also like to thank Rogosin's IT team for their support in today's presentation and the development team for helping us put it together. Again, thanks very much to Drs. Poe, Tamalapalli, and Hussein, and thanks again to Dr. Yashari and to David Wyman for their support for today's symposium.